Good afternoon. You're joining us today at the press conference at the Zika Action Summit. My name is Michelle Bonds. I am the Director of Public Affairs at CDC. Today you will hear from 5 speakers, and then we will take questions. When we take questions from the room and from the phone, please state your name and your affiliation before asking your question. Our first speaker is the CDC Director, Dr. Tom Frieden. Dr. Frieden?
Good afternoon, everybody, and thanks very much for being here. We've had a terrific response to the Zika Action Plan Summit. We have more than 300 people from all around the country here. We have over 2,000 people participating by web, and we have heard from the manufacturers of DEET that there's a lot of concern about Zika, a big increase in purchases of mosquito repellent. The bottom line here is that we are all working together to protect pregnant women. The key here is to reduce the risk to pregnant women. It has been, to the day, 10 weeks since we first issued a travel advisory about Zika at CDC. And in that 10 weeks, we have learned an enormous amount. We've done an enormous amount, but there's much more to learn and much more to do. Some of what we've learned is the risks associated with Guillain-Barré and a range of adverse pregnancy outcomes. We've also learned that sexual transmission is much more likely than we anticipated. And we've learned from focus groups with pregnant women in Puerto Rico and elsewhere that there is a great desire on the part of pregnant women to do whatever they can to protect themselves. And that's the bottom line here. The risk is to pregnant women and the developing fetus. And all of our activities need to be focused on mitigating that risk. In the past 10 weeks, we've issued a series of guidances and advice on travel, on clinical care, on testing, on sexual transmission prevention, and we've been able to scale up laboratory testing to provide Zika test kits to states around the US and to countries around the world. We're also working intensively in Puerto Rico to protect pregnant women to the greatest extent possible, to reduce mosquito populations, and to increase access to effective voluntary contraception for women who choose to delay pregnancy. Nothing about Zika is going to be easy or quick. The control of this particular mosquito is hard, and although we're learning a lot quickly, there's still a lot we don't know. There is an urgent need to both learn more and do more, and all of us have a role to play. In the federal government, there's been a terrific across-federal government collaboration involving not just us at CDC, but many other parts of HHS, as you'll hear about in a minute, as well as HUD, EPA, and many other parts of the federal government are working together to respond as robustly and rapidly as possible. In addition, we've had some very generous donations from private foundations through the CDC Foundation, and that's allowed us to move quicker and do things that we would not have been able to do otherwise, and we appreciate that tremendously. We are all in this together. There is something for everyone to do, whether it's at the federal level or state, tribal, local, or territorial level, in the public sector or the private sector, with clinicians or patients, in communities and community abatement measures. Reducing the risk to pregnant women is crucial to protect future generations. The enthusiasm that we see for this response indicates the urgency with which Zika is appropriately seen. There are many things at this summit that will be decided, determined, and moved forward in terms of state and localities doing more. But at the end, it's really important that we have the resources that we need to respond effectively, because many things do cost money. And without additional resources, we will not be able to get the resources to the state and local entities that they need for our robust response. We won't be able to do the innovations that we need to try to get ahead of not just this mosquito-borne threat, but other mosquito-borne and other threats as well. And we need the resources in order to provide Americans with the protection that they deserve. Thank you.
Thank you, Dr. Frieden. Our next speaker is Ms. Amy Pope. She's with the White House She's the White House Deputy Homeland Security Advisor and Deputy Assistant to the President. Ms. Pope?
Good afternoon, everyone. It's been a real pleasure to be here today at the Zika Action Plan Summit. This is really a critical opportunity to bring together key players, our state, local, tribal, and territorial partners, the private sector, and non-governmental organizations, as well as our federal subject matter experts, to refine our risk-based Zika action plans for states. On behalf of the White House, we're thrilled to be partnering with the National Governors Association on combating Zika in the homeland. Since late last year, we at the White House have been very concerned about Zika and its possible association with birth defects, such as microcephaly, and this rare neurological disorder called Guillain-Barré syndrome. At the President's direction, we have been working aggressively to combat this virus, taking measures to ensure that we are all prepared. We take this threat very seriously. While it's a very different disease and will require a very different response than Ebola, for example, we learned many, many valuable lessons from our fight against Ebola. Number one is the value of preparedness. As the White House Ebola Response Coordinator, I know from firsthand experience that we cannot wait until we see widespread transmission in the United States before taking steps to prepare. It's just too late at that point. That's why on February 22nd, the White House sent an emergency supplemental request to Congress for $1.9 billion to support our preparedness and response activities. Our request includes money for fortifying our domestic public health systems to prevent, detect, and respond to the Zika virus, to accelerate our vaccine research and development to provide a long-term strategy to limit Zika, to expand our diagnostic testing and capabilities, to educate healthcare providers, pregnant women, and their partners, to improve our epidemiology, to expand our laboratory capacity, to improve health services and support for low-income pregnant women, and to enhance the ability of Zika-impacted countries around the world to better combat mosquitoes, control transmission, and support the affected populations. We've asked Congress to act swiftly on our proposal to combat Zika in the homeland. Now, I know that some in Congress have suggested that we just use the money that we have to fight Ebola to fight Zika. And we've said we're going to look at all of our resources, including at some of our Ebola funding, when we're bringing the money to this fight. But we cannot undermine our fight against Ebola or all the other health epidemics that exist to take the fight to Zika. But let me be clear. Even if we take money from other pots, even if we make these very hard choices, the money we have now is not enough. Congress needs to act and do its job. We need to ensure that our state, local, tribal, and territorial partners are better prepared to protect the people in their cities and their towns. Now, at the end of this summit, we expect that state and local summit participants will go back home with action plans in hand. We are working to provide the resources to states to help implement these plans, but we simply can't do it all without help from Congress. But in the meantime, we're not going to wait. We've leaned forward in our response, especially in the U.S. territories. Puerto Rico, as you know, is experiencing an outbreak of Zika now. CDC is leading our federal response there, working closely with the Puerto Rico Department of Health and with federal partners to protect pregnant women from Zika infection. But acting now in the absence of the necessary funding is forcing us to make difficult choices about programs that protect the health and safety of all Americans. We cannot erode the gains we've made in our fight against Ebola, a fight that's not yet over, as we're seeing today in Liberia and in Guinea. We will continue to support efforts to mitigate new infections through developments of vaccines and drugs and stand ready to rapidly respond to new cases. We also continue to shore up our domestic capabilities to quickly address emerging infectious diseases when they're introduced here. But this summit, the reason we're here today, represents a critical opportunity to prepare states that may be affected by Zika in the coming months. And this is not something we can do alone. We've come here together today, and we must work together going forward to stop outbreaks of Zika and protect those who are most at risk of Zika infections. Thanks.
Thank you. Our next speaker is Dr. Nicole Laurie, Assistant Secretary for Preparedness, Health, and Response at the Department of Health and Human Services. Dr. Laurie.
Thank you, and hi, everybody. Thank you for being here. As you know, today's event is an important part of our work to be sure that states and communities across the country are prepared. In other words, that they have the plans and the systems in place to prevent, detect, and respond to Zika virus. Since the early reports of the potential link between Zika virus and severe birth defects and neurological disorders, the Department of Health and Human Services has taken proactive and increasingly targeted steps to protect the American people. Long before the first case of travel-related Zika in the United States, we pulled together all the parts of the department to be sure that we were ready and well coordinated. Although our understanding of Zika and its risks are evolving, we're focused on protecting those most at risk, as you heard from Dr. Frieden, especially pregnant women and their developing fetuses and women who may become pregnant. In addition to working with state and federal colleagues to prepare for Zika, which is of course what today's event is all about, we've activated our federal medical countermeasure development enterprise. We did this again well before Zika really came on most of the radar screen. And we did this actually for Ebola, well in advance of the Ebola epidemic. We found that when we put pedal to the metal, we could all pull together and get diagnostic tests and vaccines developed quickly. Our expectation is that the same will be true for Zika. CDC, NIH, FDA, the Biomedical Advanced Research and Development Authority, the Department of Defense, EPA, are all working together toward this goal. Right now, we're in dialogue with a great group of developers of diagnostic tests and vaccines, and we are really encouraged by their interests and their progress to date. In the meantime, CDC has already developed tests to diagnose both active Zika virus and previous Zika virus infection. But we need expanded capability, and in the long run, we're going to need more, better, and faster tests. We've also worked to ensure a safe blood supply in Puerto Rico, collaborating with the industry to develop and deploy a screening test for investigational use approved yesterday by the FDA. And as we're seeing in Puerto Rico, responding to Zika will require collaboration across government and all sectors based on strong day-to-day systems. It also requires a combination of approaches to prevent and reduce transmission, protect pregnant women who are at highest risk, ensure women of childbearing age who don't want to get pregnant have access to effective contraception, and respond to the acute and long-term health needs of those who develop complications that may be Zika related. Today's summit is an important step to ensure that those communities across the United States are prepared. As you heard, we are expecting people to be able to return home with action plans, think they can implement, be able to lean forward so that we can all do the best job we can do to protect the American people. Thank you.
Thank you, Dr. Laurie. Our next speaker is Dr. Ed Ellinger, Commissioner of the Minnesota Department of Health and President of the Association of State and Territorial Health Officials. Thank you.
Good afternoon. I'm here at the summit as the Commissioner of Health in Minnesota, along with the team that I brought with me because we're dealing with Zika, even in this northern state. But I'm here at this press conference as the President of the Association of State and Territorial Health Officials, which represents 59 states, territories, and the District of Columbia. And thanks to Dr. Frieden and CDC and the White House for pulling us all together, because it reflects the fact that this is a national problem. And because we're here and what we're hearing, it's demonstrating the need for a strong public health enterprise. We need a strong public health presence at the federal, state, and local level because it affects everybody. Even a state like Minnesota, where we don't have the Aedes aegypti mosquito, we are dealing with Zika on a daily basis in a whole variety of ways. And we all know at the local level, at the state and local level, we need a lot of knowledge and we need a lot of capacity for surveillance and monitoring at the local level, for assessment and diagnosis of individuals and communities. So we need epidemiology, we need clinical, we need lab approaches to go forward. We need to find out treatments that are necessary for this as we move, particularly with pregnant women. We need to prevent the transmission, and we need the protection of pregnant women. We need follow-up, and we need a lot of education and guidance for the public health, for medical care as we move forward. And so we have to do this all the while we continue to address the other threats that are common to us every single day that really impact our health and security. So all of this that we have to do at the state and local level and the federal level requires research, and it needs a lot of education and training like we're doing today. And it also requires resources. The majority, most people don't know, but the majority of public health services that are provided in the state are federally funded. And when you look at infectious disease and emergency response, the proportion of federal funding is immense. We need that federal support. And because we're already at a deficit in many of our funding sources, insufficient to respond to the needs and demands, just like in my state, avian influenza, Ebola, Lyme disease, West Nile virus, MERS-CoV, plus the floods and the tornadoes and the lead testing in water. And Zika has just added to the pressures in our jurisdictions. So this highlights the need for, as was mentioned earlier, needed resources. We need resources to deal with Zika specifically, but we also need resources to maintain the base level of preparedness that goes on all the time in our states. And we need to have some funding to allow us to respond to the next infectious disease or stress that we have, because we know it's coming. We've had so many kind of threats in the last 5 to 10 years. We know more are coming. So we need that kind of resources. We need to work collectively because we need a strong public health enterprise at all levels, and certainly those of us in state and local jurisdictions are pleased to be able to work with our federal partners to really strengthen that federal public health enterprise. Thank you.
Thank you. Dr. Ed McCabe, the medical director at the March of Dimes, will be our last speaker. Dr. McCabe?
Well, thank you very much for inviting us to participate in the summit. The March of Dimes is very concerned that we have a narrow window of opportunity and it will close rapidly. We have the opportunity to slow the spread of Zika into the United States over the next few months. If we're successful, we could save dozens or even hundreds of infants from being born with devastating birth defects, but we must act now. For over 75 years, the March of Dimes has worked tirelessly to prevent premature birth, birth defects, and infant mortality. For this emergency, the Foundation developed a rapid response group to monitor the CDC and other trusted sources and to update constantly our material on the web and in social media in English and in Spanish. Today, we face a virus that appears to be linked to devastating birth defects, miscarriages, and complications of pregnancy. For most birth defects, prevention is impossible because we don't know what the causes are. This is not the case with this virus. We know exactly how to prevent the birth defects caused by Zika. We must protect pregnant women from being bitten by mosquitoes that carry the virus. The real challenge then is whether our nation is going to do what's necessary to help pregnant women stay healthy. Today, representatives of state and local governments are gathering to refine their Zika plans and learn from each other. They are already committed to doing everything they can, but they cannot do it alone. Congress must also do its part. The March of Dimes and our partners are calling on Congress to pass emergency spending legislation to give CDC, other federal agencies, and states the resources they need to combat Zika virus. We're grateful for their commitment and the extraordinary work of the staff and scientists here at CDC, in other agencies, and in the states. But they should not have to fight Zika by raiding funds from other important public health priorities. Shifting money from crisis to crisis will have us chasing our tails instead of organizing a holistic, comprehensive response to these public health challenges. We don't have the luxury of time. We have a few short months to stop Zika virus from gaining a foothold in the U.S. If we don't, the consequences will be dire for affected infants. Congress must act immediately to provide the resources for us to hold back the Zika virus and to keep our families and babies safe. Thank you.
We will now take questions from the room and from the phone. In the room, please wait for a microphone, then state your name and your affiliation. I'm going to ask Dr. Frieden to come moderate the questions.
Okay.
Thank you. Is it working? Betsy McKay from the Wall Street Journal. Dr. Frieden, I just wanted to ask if CDC, you are at the point of being able to say that Zika is the cause of, fetal abnormalities and Guillain-Barré syndrome, and if not, what remains to be learned before you can do that? Thanks.
Well, we'll take it one at a time. First, in terms of Guillain-Barré syndrome, this would not be particularly surprising. A wide range of bacteria, viruses, and other challenges to our systems can trigger Guillain-Barré syndrome. The evidence is certainly highly suggestive. We've now seen one study that does show an association, though it was retrospective. I anticipate that causal connection will be confirmed in the near future. We ourselves, in collaboration with the Brazilian authorities, have completed a case control study of Guillain-Barré syndrome in Brazil. The laboratory work for that will be completed in the coming weeks. So we anticipate that will be confirmed, though I think if you look at the formal proof, you probably are not quite there yet in terms of Guillain-Barré, but I think all of us who look at it anticipate that it will be confirmed. With microcephaly, the challenge is a little bit different because it is unprecedented. It has been more than 50 years since there has been a viral cause of a severe birth defect identified, and we've never before identified a mosquito-borne cause of birth defect. So we want to be extremely careful. What is clear is that the spectrum of risk to pregnancy is beyond microcephaly. The spectrum includes apparently miscarriage and other adverse outcomes. It appears to be present in all trimesters of pregnancy, although we would anticipate that it would peak at the end of the first or in the first or early second trimester. In terms of the formal criteria for causality, that is something that we're looking at closely and we'll have more information about in the coming days.
Thank you. I'm Andrew Joseph with STAT. I'm wondering, have there been any documented cases yet of sexual transmission from an asymptomatic man? And also, are there any discussions ongoing about broadening your condom recommendations? Because I believe Public Health England has a broader recommendation than the CDC right now.
Right. So in terms of the first question, all of the sexual transmissions that we have documented have been from symptomatic males, either just before they became symptomatic or during their symptomatic period. However, if you are trying to use that to say, well, maybe asymptomatic people don't spread it, you can't really say that, because if you had an illness which is relatively nonspecific, you might not, if you were the individual who had the secondary case, tie it back to Zika if that index case was asymptomatic. In terms of recommendations for reducing sexual transmission, we've recently updated our recommendations. We have detailed guidelines and the reasoning for those guidelines on the web. There are individuals or groups that may want to have different recommendations. This is what we think balances most protection and the best interpretation of currently available data. Next question.
Thank you. I'm Erica Edwards with NBC News. There was a report out this morning that cases of Zika are declining in some parts of Latin America, like Colombia. I'm wondering if that's what you're seeing. And also, could that mean that the virus is burning out as more and more people are becoming infected and then becoming immune? Thank you.
If Zika behaves as chikungunya and dengue behaved, and that's a big if, we don't know if it will, we may see explosive spread in one area followed by a long period of lower level transmission. However, one area might be one part of a country, one city, one part of a city. So it's very difficult to predict what the pattern will be. What is certain is that the better we track, the better we can understand the trends and prevent and respond to the greatest extent possible. But we also remember that even if you have widespread transmission in a city, you might only affect 25, 30% of individuals. If we take Puerto Rico as a model, with chikungunya in Puerto Rico, it was introduced or first identified on May 5th of 2014. Within 8 weeks, it was all over the island. Within 8 months, 25% of adults were infected. But it continues to spread in Puerto Rico 2 years later. If we take dengue in Puerto Rico as an example, it has spread there for a while, and now 80-90% of adults have antibodies to dengue, have been infected with at least one of the dengue types. So the virus, unfortunately, doesn't burn out. It may spread with greater intensity or less intensity. All right. Sorry, go ahead, Mike.
Okay. Hi, Mike Stobie from the Associated Press. Dr. Lurie talked about tests, the need for better and faster tests. Could you say again, how long does the PCR test take to bring back results? How long does the antibody test? And could you say, some people have said that if we do see local transmission in the fall, there'll be a great concern and a great demand to have test results immediately. Is it likely that we will have a test in place then that would give concerned women a test result that day or within a day?
Well, I'll start, and then Dr. Lurie will continue. First off, let me go through what the types of tests we have out there. There's the PCR, or polymerase chain reaction, and CDC has just gotten approved through the Emergency Use Authorization Program of FDA, a trioplex PCR that we developed in our laboratories that tests at one go for dengue, Zika, and chikungunya. That test actually has to be incubated overnight, so it takes a day or two to come back with the results. That's what the science maximally allows. And we can produce hundreds of thousands of those tests and have those available. But that only identifies virus when it is present, when the RNA is present, which is roughly a week in the blood, maybe a little bit longer in urine. That's something that needs to be studied. The more challenging is to see if a prior test is, if a prior infection has been present. That we use with an antibody test, or IgM macrolysa. That's also a CDC-developed test, which the FDA has issued emergency use authorization for. And we're rolling out through the Laboratory Response Network to states all over the U.S. so they can offer testing. It takes some time for them to validate the test and begin offering it, but an increasing number are doing that in the coming weeks. If the macrolysa is positive, the confirmatory testing needs to be done by a neutralization assay that is done only at the CDC laboratory. And that takes about a week to occur because you actually have to grow the virus. And the virus doesn't grow that well or that quickly for that to be able to be done. So the testing is much more available than it was, and that is due to literally around-the-clock work of a superb team of laboratory specialists at CDC, but it's not as available as we wish it were. I'll speak a moment about some of the innovations that our labs are doing, but we really do need the commercial sector, the private sector, and others to come forward and do more. Roche Diagnostics came up with a test for the blood supply that FDA approved yesterday, which is terrific. It means that in Puerto Rico, they can soon go back to collecting blood, screening it for Zika, and using it. And that's a very important development. There is work being done on the point-of-care test, and Dr. Lurie may speak more about that. What we're doing at this point is optimizing both the macrolysa test so that we can produce it more rapidly using virus-like particles. It's a cutting-edge technique to be able to produce large numbers in shorter periods of time, and the lab has worked around the clock and will be able to, I think, increase production capacity through that means. For that neutralization assay that requires the virus to grow, as soon as this happened, the team had a great idea, which was to create a viral chimera, create a new virus to be able to use in the lab using a faster growing virus, but with the Zika proteins embedded, or DNA actually, embedded into the virus genome so that it would produce the Zika antigens, which could then be tested against. So if that's the case, if that works, then we'll be able to cut that 1 week confirmation down to a 3 or 4 day confirmation with a faster growing chimeric virus. So those are some of the innovations we're working on. But bottom line is, without significantly increased resources, it's going to be very difficult to do the kind of innovations we need to do to provide rapid testing and rapid control. Dr. Lurie.
Sure, thanks, and thanks for the question. Our focus has been primarily on developing diagnostic tests that will be able to tell a pregnant woman whether she has been exposed or contracted the Zika virus. We're also interested in improving the diagnostic test capacity for people who want to know, am I infected now? So I think you understand now the difference between those two kinds of tests. We are working very aggressively with a whole host of diagnostic test developers to do that. As Dr. Frieden says, it takes money. And we're in a little game of cat and mouse here because some of the developers are a little reluctant to put a lot of skin in the game until they know that there is going to be money to support those efforts. Nonetheless, we are leaning forward as quickly as we possibly can to do that. One of the lessons that we learned from Ebola was that in order to get to the commercially developed tests, the manufacturers are going to need to validate their tests against a whole bunch of Zika positive samples, and they're going to need to be able to demonstrate in a lot of samples that they can differentiate Zika from dengue or chikungunya, as you heard about that cross-reactivity. One of the things we are in the process of doing now is trying to compile and sort of curate a whole series of diagnostic validation panels so that the developers actually have that material to move forward with to develop their tests. It typically hasn't been anybody's real responsibility to do that across government. We all got together, recognized that as a government responsibility, and we are actively on that now. But that requires us finding 50 or so people who have had recent confirmed Zika virus disease, going to where they are and having them be willing to donate blood for that. We're in the process of doing that, and our goal is to meet the developers with those diagnostic panels when they are ready with their tests. So that's all in train.
Thank you.
Hi. Mary Boyle with NHK Japan Broadcasting. With regards to the efforts in hard-hit areas such as Brazil and Colombia, what do you think of the conflict between the guidelines issued by the CDC and those countries' legal and cultural issues with contraception?
Our goal in terms of contraception is that any woman who chooses to delay pregnancy has ready access to the most effective forms of contraception. We have a good experience in this country expanding access to long-acting reversible contraception. We know that long-acting reversible methods are much more likely to succeed. And so certainly for any part of the U.S., we encourage local healthcare providers and jurisdictions to make effective contraception possible and readily available, not just possible in theory. We're encouraged by some of the comments from various religious leaders, understanding that in such an unusual time, there are important resources that women can avail themselves of. In addition, we think it's very important to continue the focus on reducing the risk to pregnant women. This is the essential both target of the Zika virus and target of our response in terms of maximizing that protection. I want to reiterate that within the U.S., including Puerto Rico, we do not have a recommendation not to become pregnant. We do have a recommendation that if a woman and her partner choose not to become pregnant, that there be ready access to effective contraception.
And I have one follow-up question. Do you feel the CDC is being too cautious with its guidelines at all?
Too cautious on anything in particular?
For example, infected men are advised to wait, I think it was 6 months.
We are being maximally protective. The key here is to protect pregnant women. It may well be that the viral persistence in semen is only a few weeks, but we have no idea if that's the case. And therefore, we say that if a man has been in a Zika endemic area and his sexual partner is pregnant, he should wear a condom every time he has sex. I think there was another question here.
Megan Packer, CBS 46. What are some of the most important steps to be taken right now in the U.S. at the local and community level?
First off, women who are pregnant should not travel to areas where Zika is spreading. Men who have been in areas where Zika is spreading and have a sexual partner who's pregnant should use a condom. And in areas of the U.S. where Zika is spreading, such as Puerto Rico, pregnant women should use mosquito repellent, long sleeves, screens on their windows and doors, and take steps to reduce mosquito populations. This summit is working through action plans for every jurisdiction that is affected. That means making sure that they're prepared to monitor and respond as effectively as possible. Maybe, Ed, I'll ask you to say more about what jurisdictions are doing.
Thank you. Yes, certainly throughout the country, the states and territories are here to really learn what's specific for their area. So what's happening in Houston, where they have the Aedes aegypti mosquito, they're doing a whole lot of different things in terms of their mosquito spraying, with their mosquito control district, and with the education, and with the social media that they are doing to educate folks about decreasing the risk for exposure to mosquitoes. Certainly in Minnesota, where we don't have the mosquito, we're really educating our providers. The general population about travel is in particular, and about people coming back from travel, but also we're explaining to our OBGYNs and the physicians in our clinics how to talk to folks about travel, how to do a travel history when they come back. So it really varies from point to point across the country, depending on the risks that are there. A lot of the things that Dr. Frieden mentioned are being implemented in the localities throughout the country, at the local level and at the state level.
Okay.
Dr. Frieden, Maren McKenna, National Geographic. Dr. Frieden, Dr. McCabe made reference to dozens, possibly hundreds of infants who might be affected by birth defects. At CDC, have you been able to come up with any possible numbers for the potential public health impact of Zika on the mainland U.S.?
We don't want to speculate about what may happen. We want to maximize our preparedness for what we can prevent from happening. The front line of the battle against Zika in the U.S. is Puerto Rico. And we are very concerned that Puerto Rico could have hundreds of thousands of Zika infections and potentially thousands of pregnant women infected with Zika. Within the continental U.S., it depends very much on several things. How many women travel? We've already had dozens of pregnant women who've traveled and become infected. So the fewer pregnant women travel to Zika-affected areas, the fewer Zika-affected pregnancies we're going to have. We've already had at least 6 sexually transmitted Zika infections to pregnant women. I'm sorry, that's not true. 2 to pregnant women, 6 sexually transmitted infections total in the U.S. And in terms of local transmission within the U.S., we've seen with dengue and chikungunya that there can be clusters in local areas. We've seen that in Florida, we've seen it in Texas, and we've seen transmission of dengue in Hawaii. So in those areas, we need a maximal protective response to track the mosquitoes, control mosquitoes, and reduce risk to pregnant women. But we don't have specific projections of what might happen. We are looking at what might happen globally, but there are just too many unknowns. And perhaps one of the most important unknowns is what is the range of fetal abnormalities in addition to microcephaly? Microcephaly is not a diagnosis, it's a description. It's a description of a devastating fetal malformation that has occurred and has interrupted normal brain development. And it is highly likely that infants who are not affected with microcephaly but do have Zika transplacental infection will have some other effects. Whether those effects are apparent in the short term or long term will be very hard to say. Ed, do you want to say anything more on this?
Well, I agree. When you see a new syndrome, which is what we're seeing here, you see the extreme of the syndrome. But as Dr. Frieden has said, we don't know the impact that lesser infection may have on that baby for the whole baby's life. And to the point about projection, we just don't want to see that experiment happen in the U.S. There is no reason why we should come back 2 years from now and say we were right or wrong about our projections. Let's stop this. We know what we need to do to stop it. Let's put the resources out there to stop it, and not play a numbers game 2 years from now.
Thank you.
Afternoon, Jonathan Seri with Fox News. This morning we saw a map showing a rather disjointed patchwork of mosquito control districts. What is your best advice to local governments on how they can sort of unify or coordinate that patchwork?
Yeah, this is one of the real challenges. And really, if there's one bottom line I have for today's summit, we need sustainable mosquito control capacity throughout the country. And whether it's Zika or West Nile or dengue or the next vector-borne threat, it's so important that we have the resources there. And we will do whatever we can at the federal government, but state and local governments also need to do more. Mosquito abatement districts range, as you heard today in the morning session. One of the questioners commented that some mosquito abatement districts are very powerful and very effective, and others are basically the guy who shovels the snow in the winter, does a little bit of fogging in the summer. So they're quite variable in their capacities, and that's one of the reasons we need money from Congress. But in addition, state and local governments also need to invest in mosquito control in the long term. Amy Pope?
So the issue you raise is exactly why we're having this summit today. What we realized was that there was no sort of set of best practices for people who wanted to control this vector out there. But we do know there are very good instances of communities that have been able to better manage the vector. We know from our experiences with dengue, for example, that there have been very good practices that are in place. And so the goal of today's summit is to bring all of those practices together in one place, give folks sort of the menu of options so that they can develop a comprehensive plan well in advance of when we see mosquitoes biting around the continental United States.
Great.
Janine Interlandi, Consumer Reports. Can you talk a bit about resistance and if resistance testing is being done extensively and how it's informing guidelines with respect to insecticides and bug sprays?
Thank you. In terms of resistance, most of our work has been in Puerto Rico, which is most heavily affected. We set up a laboratory for resistance in Puerto Rico. I've visited it. I've seen the resistance testing they're doing. It's quite impressive. It's not easy. You have to go out and collect the eggs of the Aedes aegypti mosquito. Then you have to grow them and wait till they hatch and grow into larvae. And then when they're adult, you have to put them into a bottle. It's the CDC bottle method. It's very simple. You basically take a glass bottle and you roll insecticide around until it covers all of the parts of it. And then you put 25 mosquitoes in there, which is harder than you might think, or easier than you might think. And then you measure every 15 minutes what proportion of those mosquitoes are knocked down. And I was able to see the techs doing this. Unfortunately, in Puerto Rico, many of the pyrethroid insecticides have a high degree of resistance. So I saw very effective insecticides with the mosquitoes flying happily around an hour later. No effect whatsoever. At least one of the insecticides, all the mosquitoes were knocked down within 15 minutes. What we found in Puerto Rico and what we're finding in Mexico and elsewhere in our international work is that insecticide resistance can be quite focal. Remember from Dr. Peterson's talk this morning, these mosquitoes don't fly that far. And so you might find, as we found in Puerto Rico, that there was no one pyrethroid that worked in the entire island. That makes mosquito control even more complicated and even more technically challenging because you have to then match the insecticide used to the resistance of the population. This is another area in the US where we need much better data and much better testing. It is in some ways similar to antibiotic resistance, where you want to know the resistance pattern before you use antibiotics and sometimes use them in rotation or combination in order to prevent the further development of resistance. Other questions?
Thanks. I was curious, you talk about each state should have a plan. How many states have plans, and how many states say they have the staff and money to implement the plans right now?
Well, I think it's safe to say that no state would say they have enough money and staff to respond effectively today, because this is a big challenge. There's a shortage of entomologists out there. there's a shortage of dollars to do the extensive things that are needed. I think the great majority of states have done a lot to prepare, but this summit is to accelerate that action. I'll ask both Ed and Amy to say more.
This is a rapidly changing environment, and so what ASTO is doing, the Association of State and Territorial Health Officials, we are surveying all of our members to look at what they are doing, what resources they're putting into it. Also, we're asking them what things are they not doing in response to changing those priorities. So we'll be getting that information. We know that everybody is paying attention. We've had multiple calls with all of the state health officials throughout the country. We've had several calls about this. Everybody is working on it. They're doing different things. As I mentioned earlier, the needs are a little different in Hawaii and Texas and in Florida than they are in Vermont and Washington and North Dakota. But everybody's working on it in some way, shape, or form. We're trying to collect all of that so that we can feed that back to CDC to say what are the needs that are out there, how do they vary, what kind of resources are they needed, where do we need to focus some of our attention, and we'll be getting that, I'm hoping, within the next few weeks as we survey that our colleagues.
I'm just not clear. Does anyone have a complete plan? Somebody said that you get your plans at this meeting and then you go. Does anybody have a completed plan, or are you saying everyone's drawing them up right now?
Right now, there's no definition of a complete plan. We're learning every single day about new things. We're learning what issues are out there. We're learning how the virus is moving, how people are responding, getting new information. So some people have really robust plans, from mosquito control to testing to education to social media. But is that a complete plan? We don't know yet, because we don't know all of the things that we don't know.
I'd only add that this is not the first time that we're starting this conversation. Back in February, when all of the governors were in Washington to meet with the president, we came together and realized that we very much needed this kind of planning because of, as someone noted, the patchwork of mosquito control efforts around the country. And so since that time, CDC and our other federal partners have been working with states to develop their plans so that people coming into this already have something in hand. And then the goal is that today they walk out and they import the expertise and the knowledge that they've gained from their colleagues. But as folks have pointed out, we are learning something about Zika every single day. And so I would challenge anybody who says they have their complete plan in place, because we believe that it's just going to need to be adjusted as we learn more.
Thank you, and we'll take a question from the phone and then.
Thank you. Our first question from the phone is Dennis Thompson with Health Day. Your line is open.
My question's been answered. Thank you. Sorry about that.
I'm Donald McNeil from the New York Times. If this was World War II, and you went to Congress asking for money to fight the Japanese, and their response was, well, take it from the money we already gave you to fight the Germans, you would find that an almost absurd response. I can't, and you'd be able to explain it that way. I can't think of a time when Congress has looked at a new epidemic and said, forget it, go take the money from one of the old ones. And we've had a series of epidemics in this country. Could anybody, either Dr. Frieden or from the White House, comment on why you're running to this kind of resistance once with this disease? Because it hasn't happened before. What's the answer you get when they give that absurd answer?
Well, I think what Congress is doing is asking the American people to choose between which disease they want the most protection from, and that just doesn't make a lot of sense. When we worked with Congress to get the money for Ebola, we believe they actually showed quite a bit of foresight in saying that we're not going to fight this epidemic by epidemic. We're going to make an investment in our global health security. And we, with the money, the investment that they made, have been working with countries around the world to put together plans to prevent, to detect, to respond emerging diseases. And we think this will ultimately make America safer, because we will see things like Zika coming. We will see things like Lassa fever or Ebola as these outbreaks happen. And so, frankly, we don't think this is funding epidemic by epidemic makes a lot of good policy sense. We don't think it's fair to ask Americans to choose. And we're hoping that Congress will do the right thing and they'll act.
I would also comment that Ebola is not over. In fact, just this morning, a new case of Ebola was confirmed in Liberia. Sadly, a woman who died with Ebola was confirmed with rapid diagnostic tests and then PCR. and that investigation is underway. We also have a cluster in Guinea that we're following up on. And with the global health security dollars that Congress invested, we're confronting a very large outbreak of yellow fever in Angola. We're dealing with Lassa fever in Benin, Togo, and Nigeria. So it's a dangerous world out there. And the more we can stop diseases from spreading overseas, the safer we can be here at home. We have another question on the phone, or maybe one that hasn't been answered.
Thank you. We have a question from the phone. Donna Young with Scripps News. Your line is open.
Thank you so much for taking my question. This is for anybody, Dr. Frieden or Dr. Lurie. Talking again about the projections, going back to, have you actually provided any sort of cost estimate to Congress, not specifically looking at, this disease, but the cost estimate of birth defects in general, and maybe compare that to the cost of developing vaccines and treatments to prevent this from infecting pregnant women? Has there been any kind of economic analysis presented to them as an argument as to why they need to provide this funding to develop the vaccines?
Thank you. I'll make a brief comment and then ask Dr. McCabe to say more. The request to Congress is $1.9 billion, of which $828 million is for CDC. That part of the CDC request covers both our continental U.S., the Puerto Rico and the territories, and our international activities. Our birth defect specialists tell us that a single child with a severe birth defect can easily cost $10 million to care for or more. Dr. McCabe?
Yes, this is, I don't think we can take all of birth defects and, talk about these babies. First of all, we only know the severe, and this is really severe microcephaly that these babies are experiencing. This is devastating. I was chair of pediatrics at UCLA for 16 years. A paper in the New England Journal a couple of weeks ago out of Brazil was from the team there. And they were telling me that just it's the future of these babies is going to be very, very, very difficult. We really need to stop that so that we don't see that occurring in the U.S. to the degree we've seen it in other countries. But the costs are going to be terribly high for the life of that child. Unfortunately, some of these children aren't living very long. So I think it's difficult. We don't have the experience yet to know what the life is going to be. And again, back to those babies that we see in the pictures from Brazil with the severe microcephaly. We can see them. We know how devastated their brains are. What about the baby who is born and had placental insufficiency, also in the same New England Journal paper, and is small? All of the organs are small because the placenta could not provide the nutrition required for that baby to grow normally. We don't know what the future of that baby is going to be. And then for the babies who may not even show growth problems, but may have as yet unknown problems with their brain development, with learning, school. We just really don't know what it's going to be like, but it's very concerning what we're seeing so far.
Thank you. We'll take another question from the phone.
Thank you. We have our question from Evan Brown with Fox News. Your line is open.
Thank you. Actually, my question has been asked already and answered, so I appreciate the time, but someone else can have it. Thanks.
Okay. Do we have another question on the phone?
We're showing no further questions from the phone.
Any more questions on the room? In the room. Okay. One more here.
I'm going to go off topic with Zika for just a moment, only because we don't see you face to face very often. I'm here in Atlanta with 11 Alive News. Just yesterday, we heard that there was a CDC worker who got infected with salmonella. So I just wanted to have you tell us how that happened. Is anything being changed, just from your perspective?
The investigation is underway. What we've committed to doing and what we have done here is be completely transparent with anything that occurs in our laboratories. One individual worker, a trainee, who had been fully trained in safety, does appear, not confirmed, but appears to have been infected with salmonella in the laboratory. They're well, they're recovered, they're back at work. No one else was affected, nothing was released. And we created, as a result of the recent incidents, a laboratory leadership service. This is a set of laboratory detectives analogous to our epidemic intelligence service. They are investigating. They have identified what they think is the probable cause, and we've already issued to the entire agency mitigation measures that would prevent that from happening again. I think we have one last question here.
Oh, yeah. I just want to clarify numbers. First of all, did you say that 2 of the 6 sexual transmissions were pregnant women? And also, when you were presenting earlier, I wasn't clear on how many dengue and chikungunya cases had been reported in Texas and Florida before. I think you said 24, but then there was a little further discussion, and I didn't quite catch what the final count was.
We can get back to you with those exact numbers in both cases. Last question. Wait for the mic.
Dr. Frieden, could you, of the cases in the United States, I know CDC had reported some of the outcomes earlier in the earlier paper. Do you have any more update to give us? Because I think WHO reported in their latest report that there was a woman from Cape Verde who gave birth to a full-term baby with microcephaly here in the United States. So what can you give us the broader context, the numbers of microcephaly cases?
So we are now monitoring within the continental U.S. About 36 women who've been infected with Zika at some point. We've seen many. What's the exact number? Do you know offhand? I want to make sure to get that for you. It's in the 20s and 30s in Puerto Rico and the territories. It's in the mid-30s. 21 in the continental U.S. We've already seen several miscarriages among those women. We reported earlier outcomes. The case you mentioned, although delivered in the U.S., was reported elsewhere because of the way that disease reporting is done. There was the earlier case reported in Hawaii, and we'll continue to provide those outcomes as the pregnancies progress.
So can you characterize what stage of pregnancy? Are they mostly? Are they first, second? I mean, where are we in the pregnancy?
We've seen all stages of pregnancy, and some for which the stage is still being determined. We have seen some women, particularly in Puerto Rico, who appear to have not had symptoms, so that obviously makes it difficult or impossible to know what stage of pregnancy they might have been infected in. We'd be happy to get you more information afterwards. I want to thank everyone for being here. There's an enormous amount of work being done across all levels of government. Across the U.S. government, you have the White House here, HHS, across state and local governments, you have state health departments represented here. With the private sector, you have the March of Dimes here. This really is all in response to reduce the risk to pregnant women. All of us have a role to play, and we need to do that, and we are doing that with a great sense of urgency and commitment. Thank you all very much.
This concludes our press conference. If media have follow-up questions, please call 404-639-3286 or email us at media@cdc.gov. All others, there's information on our website about Zika. Transcriptions from this press conference will be available at our website. Thank you.